Good afternoon. Today we are discussing about the topic is pressure ulcers. This is the wound management first part. So we are starting pressure ulcers or decubitus ulcer. First of all, we just discussed about what is pressure ulcer. I think all of you know about pressure ulcers. What is that? How it can be happen for patients? Anybody? What do you mean by pressure ulcer? Anybody?
Please respond or you can put to your chat.
That's all. Okay. Why it happens? So, pressure ulcer is a localized injury to the skin and other underlying tissue, usually over a body prominence, as a result of prolonged unrelieved pressure. Exactly, due to the friction or unrelieved pressure to the particular area, it will affect the skin integrity. So it will cause some sores like or wound like appearance into that area, that is called pressure ulcer. The main reason of that ulcer is pressure. So that's why we called it as pressure ulcer. Is it clear?
Yes, ma'am.
Okay, thank you. Anybody, you can tell me about what is the reason of pressure ulcer? Any of them? What is the main reason of developing pressure ulcer? In what kind of patient can develop pressure ulcer? Did you say pressure ulcer? Anybody? Bedridden. Okay. So pathophysiology, how it happens? That is pathophysiology. So if one of the members reported that bedridden patient may develop pressure ulcer. So for a bedridden patient, there is a chance of prolonged pressure to a particular area. Sometimes maybe bedridden, sometimes the patient may be wheelchair bounded. That case also same criteria will happen. The pressure for a long time applied to the particular area. That time the collapse of blood vessels to that area. It will affect what happen whenever the collapse of blood vessel happens means there is a tissue perfusion may be affected. Along with that, nutrition and oxygen supply also be reduced to that area due to the collapsed blood vessels. Due to the tissue perfusion affection and oxygen decreased oxygen level, so there is a chance of tissue ischemia. This leads to the hypoxia and it leads to cell death. Due to the ischemia and hypoxia, at the end result was cell death. This will cause the stress or breakdown of the skin to that particular area. So that is, if a bedridden patient continuously lying on the bed means there is a mattress will cause a pressure to the back spine. The collapse of blood vessel will happens to the back of spine or sacral region. Anybody that according to the position of the patient, it affects the oxygen supply and leads to the hypoxia and cell death. That is called as pressure sore. Pressure sore. So this is the pathophysiology of pressure ulcer. What are the risk factors of pressure ulcers? First one is friction. Friction means nothing but while transferring the patient or some friction between the bed sheet or patient body may leads to the pressure ulcer. So shear injury, impaired sensory perception. The sensory perception is impaired means patient don't know about pain and all. So there is a chance of getting pressure ulcer. So impaired physical mobility, altered level of consciousness, fecal and urinary incontinence. In fecal and urinary incontinence, skin always contact with the fecal matter or urine that may leads to the skin integrity changes. Then malnutrition. Malnutrition may leads to the tissue hypoxia and tissue decreased tissue perfusion may leads to the pressure ulcer. Then dehydration. At the time of dehydration, skin will become very dry. There is a chance of getting skin breakdown. So excessive body heat. Maybe due to the excessive body heat, there is a chance of getting so much of sweating that will cause the moist environment to the surrounding skin area. That also after the friction that will causing the skin integrity damage. So advanced age in advanced age and frailty and there is a chance of getting impaired mobility that will leads to the skin integrity perfusion. Then these are the some we can detailed monitoring is there. So common site of pressure ulcers are mainly back of head, shoulder blade, lower back and heel. According to the positioning of the patient, the site may be varying. So this is the common site of the patient. In supine position, there is a chance of getting pressure zone in the back of the head, shoulder blade, lower back and heel. In right sideline position means there is a chance of ear, elbow, hip and between the legs or knees. In wheelchair bounded patient, there is a chance of pressure sore in the hip region, sacral region, lower back, shoulder blade and the heel. We can go through detailing. This is some types of stages of pressure ulcers are there. The common site of pressure ulcers in the supine position. First one is occiput, elbows, sacral region means buttocks and elbow is there, heel is there and toes. In heel is contact with the foot end of the bed and toes also contact with the foot end. So that's why there is a chance of getting pressure ulcer is more in the supine position. Next is sideline position. In sideline position, in both sideline position, according to the position, the side may be varying. So, ear is there, shoulder is affected, elbow, outer aspect of the elbow. In supine position, the back of elbow is affected and hip is there, hip or thigh region and knees, outer side of knee, heel, ankle and inner side of the unaffected side that may be affected in the sideline position. In Fowler's position, the occiput may be affected, shoulder is affected, sacrum is affected, and buttocks and heel. The common site is heel, and buttocks may be affected for the all patients. And prone position, head is affected, and elbow, chin of the patient, and chest region reproductive organ may affected and knees and toes. These are the prone position affected areas of pressure ulcer. And stages of wound. What are the stages of a pressure sore? Anybody? How many stages are there? 4 stages, okay. What are they? Only 4 stages. Any other answers? All of you agree with that? Only 4 stages are there. Okay. There are 5 or 6 stages is there for pressure ulcers. First stage is non-blanchable erythema. That is nothing but it's a color change only. There is no breakdown of skin will happen to the first stage of pressure ulcer. In this, red or differently colored spots that do not blanch with the pressure. That is non-blanchable erythema. That is called first stage of pressure ulcer. It's look like a this picture. So there is a non-blanchable erythema is there. There is maybe there is no skin integrity damage will be there. Next one is stage 2. It's a blister formation. It's a partial thickness skin loss will be there. First layer of skin will be damaged after the pressure application. So sometimes it may be a blister. So shallow open ulcer into the dermis. Otherwise or serum filled blisters. This is the second stage of pressure ulcer. First stage is non-blanchable erythema. Second stage is serum filled blister or shallow open ulcer into the dermis. Otherwise called as partial thickness skin loss. This is the second stage of ulcer. Third stage, there is a full thickness ulcer is there. Along with that, sometimes tunneling also present. So tunneling wound is categorized under stage 3 pressure ulcer. Remember that if anybody saw a patient with pressure ulcer with tunneling, it is under stage 3 of pressure ulcer. Sometimes full thickness ulcer is not visible to that area. Only tunneling is there. That is categorized under the stage 3 pressure ulcer. So tunneling is nothing but a narrow opening or a passageway that can extend in any direction through soft tissue. So, while assessing the tunneling or assessing the wound, you have to mention the stage of ulcer. So, you have to remember what are the stages are available or what are the stages is present for the pressure ulcer. So, the tunneling is there. You have to measure the tunneling. So, we can assess the tunneling measurement according to the clockwise directions. So 12 o'clock, this much is measurement. 7 o'clock, this much is measurement. Like that, you have to mention the tunneling. Is it clear? Any doubt? Okay, stage 4. It is full thickness wound, exposed muscle or bone or tendon. This is the stage 4 of pressure ulcer. So 4 stages are we covered. First one is non-blanchable erythema, partial thickness wound, full thickness with tunneling, partial thickness with tunneling. Fourth stage is full thickness, exposed muscle, bone or tendon. So this is the 4 stages of ulcer. Along with that, another stage is there that is called stage 5 or unstageable. It is categorized under stage 5. In stage 5, there is a slough or eschar present. The eschar is a blackish discoloration. The dead tissue will be covered the wound. Once we have to assess the stage of ulcer, first we have to remove the slough first. Then only we have to assess the exact stage of the wound. So this is categorized under unstageable or stage 5. Pressure sore is unstageable if it has a slough or eschar on the top. First we have to remove the eschar. Then only we have to set the stage of the wound. Sometimes it will be very hard. So we have to soften the eschar. But once it will get moist means we can remove the eschar easily. Stage 6 is deep tissue pressure injury. So it is a non-blanchable deep red, purple or maroon discoloration prolonged due to the prolonged pressure or shear forces. In this, tissue damage from inside out. Sometimes it may be stage 3 or stage 4. This is categorized under deep tissue injury. In outside, the tissue will be just color change will be there. Then, but the exactly inside is more worsened. So we have to. It is categorized under deep tissue pressure injury. Next is assessment of pressure ulcer. For that, doctors and nurses must assess the patient's skin at each visit of the bedbound and wheelchair patient. For what? For what reason we have to assess the patient for any condition? All of you nurses know for what reason you have to assess the patient? Nobody assessing the patient, no?
Please respond to the faculty.
In order to diagnose and plan care. Okay. Only for diagnosis or plan of care? Okay. In our setting, if we are receiving a patient or otherwise we have to see a patient means first we have to take a detailed history from the patient side, and if the patient is not able to tell the history means we have to collect the history, proper history from the bystander. Okay, so for what means we have to assess the patient for a detailed report and give a proper care for the patient. So if a patient with bedridden or wheelchair bounded, first priority is we have to assess the symptom first, then we have to cover the skin. So okay, for what reason means we have to assess the each and every pressure points of the particular patient according to their position. So we have to assess the pressure points. Then, yeah, if the patient is having wound means you have to assess the pain. If any pain is there, you have to talk with the patient. If any pain is there, you have to manage the pain first, then only go for the wound management. And next one is assess the location of the wound. So first one is pressure points. If the patient is not having any pressure ulcer means you have to assess the pressure points. And if the patient is having wound means you have to assess any pain is there. and assess the location of wound and measure the width, length, and width of the depth of the patient, the wound. Then stage of wound. We already covered the stages. There are 4 to 6 stages is there. So if you know the wound stages means you can assess the wound stages. So you have to assess the stage of wound. Then presence of exudate. Exudate is nothing but any discharge from the pressure ulcer. That is any oozing is there. If any exudate is there, you have to assess the characteristics of the exudate. Sometimes there is a serous fluid is coming out from the wound. That is healthy. So there is no need for any antibiotic or any other treatment. Sometimes it's a purulent discharge with color changing, malodor is there. So you have to report to the duty doctor and do the needful. So then is assess for tunneling. We already discussed the tunneling and how to take the measurement. You can take the measurement with the artery forceps sometimes with your little finger, sometimes with the pulse swab, no. So you have to assess the tunneling. Then chart the findings. That is nothing but recording. Okay, we have a wound chart is there. You can mention the stage of wound, site of wound, then the measurement and the characteristics of the wound. So you have to assess properly. Then management. First, I already told you that you have to manage the pain first, then only go to the wound care. So always medicate the patient for pain before wound care. If sometimes patient may be taken any opioid means you have to give a opioid at that time before dressing. Then after 30 to 45 minutes, then only you do the wound care. So in management is different for different stages. In stage 1, we know that is a non-blanchable erythema. There is a no skin damage is there. There is the prevention is sometimes needed. So teach the caregiver to take an excellent incontinence control. So in stage 1, the management is caregiver education regarding the positioning and incontinence control. In second stage, there is a partial thickness wound is there. The first layer of skin may be damaged. So we have to clean the wound with normal saline and plain dressing is needed for that type of wounds. In stage 4 or 5 or unstageable. In unstageable means there is a chance of presence of slough is there. If the slough is there, sometimes it is very hard. So you have to moisten that slough. It may be taken 4 to 5 days, sometimes weeks may be needed. So you have to soften the slough. Once it comes to detached from the skin, you can remove that. So this is the in unstageable wound. If it is in a stage 3 or 4, you can use the normal saline for wound cleaning. You can use the homemade saline in house visit and all. So after that, you have to put the biolin dressing. That is nothing but white petroleum jelly. For soften the slough, you have to put the thick biolin coating to the slough area. In malodor is there. That is a chance of sign of, no, not a chance, there is a sign of infection. So you have to add metronidazole powder. You can use the dressing. So metronidazole powder you can use. Along with that, injection metrozil for irrigation to the wound site. In slough area, there is a sometimes the slough may be in yellowish discoloration. The papain ointment is very helpful. So you can use the papain ointment for the slough removal. Then Mega Heal, it's a nano silver colloid ointment. It's a healthy wound is there. You can apply the Mega Heal for the easy healing. Is it clear? So next one is charcoal dressing or charcoal. You can put the some charcoal clips on the dressing in between the dressing pads. To it will absorb the excessive malodor. So charcoal is help to preventing the malodor. Then we have to don't use the hypochlorite solutions like povidone iodine and hydrogen peroxide to the bed sore because it is unhealthy to the tissue. So you don't use the povidone iodine or hydrogen peroxide for the bed sores or wound management. And surgery consultation. Sometimes the channeling is very more. In these conditions and all, you have to consult a plastic surgery or surgeon for the further management. There is a sometimes there is a need of any surgery. Then negative pressure wound therapy. This is a we are not using negative pressure wound therapy. There is a suction will be attached to the wound. There is a so much of exudate is there. This section will collect the excessive exudate and a negative due to the negative pressure applied to that area, and this excessive exudate will be collected to the section. He already just discussed the homemade saline and dressing supplies. So how to make the homemade saline means in local areas and the normal saline is actually not available. So you can tell them to make the normal saline. So how to make normal saline means you can tell them to take the 500 ml of water and add 1 teaspoon of salt and boil and cool and keep it in a airtight cover or bottle. So because means we have to use the homemade saline means we are treating a unsterile wound. It's the bed sore is considered as a not a sterile wound. So we can use the normal saline for cleaning and dressing for the wound. So next one is goes how to make a dressing supplies goes how to take the dressing pads or how to make a dressing pad easily means take a old cotton sarees or dhotis and cut them into the squares and steam them for the half an hour to 1 hour with the steamer. It can be mixed with Vaseline and liquid paraffin and you can use it for the wound care. So prevention of bed sore. Once if a patient is bedridden, you have to tell them the prevention remedies for the pressure ulcers. Then only go on for the management. So first you have to tell them to prevent the pressure ulcer. So for the prevention, first one is position change. Every 2 to 3 hours, you have to change the position of the bed-bounded patient because once they get a continuous pressure over a particular area, that will affect the blood supply and will lead to the pressure ulcer due to the tissue injury. And every in bed-bounded patient, you have to position the patient every 2 to 3 hours. If the patient is chair bounded, every 15 to 20 minutes you have to change their position. Otherwise, they instruct them to take a push-ups with 20 seconds. So, in every 15 to 20 minutes. 20 seconds push-ups in every 15 to 20 minutes. That is enough for pressure relieving in the chair-bounded patient if the patient is having upper limb strength. So next one is manage incontinence. We already discussed that incontinence leads to the pressure ulcer due to the moist environment may affect the uh, disturbance of the skin integrity. It may cause the skin tissue damage and leads to the pressure ulcer. So management of incontinence of bowel and bladder is very important. Then next one is special surfaces. What are the special surfaces means? First one is air mattress, water mattress, and the support of extra pillows and cushions. And air mattress and water mattress, it's a pressure relieving techniques. Once we have to give a air mattress or water mattress also, you have to do the positioning of the patient. Otherwise, it also leads to the pressure ulcer. And proper nutrition and hydration and exercise for the patient. And massage with liquid paraffin or white petroleum jelly. Because once a patient is bedridden, if you are doing positioning means you have to do a simple massage to the back also and the pressure areas. So it will lead to the blood circulation and we can maintain the skin integrity to the particular area and help them to make a wrinkle-free bed. If a wrinkles in the bed means it also causes extra pressure to the particular skin, so it may be leads to the skin damage. Then nail care. If a patient is dehydrated or otherwise sometimes maybe very dry skin is there, it will causing itching. That time the patient may leads to the scratching over the particular area. It also leads to skin integrity damage. It may leads to the small injuries to the, or cuts to the skin. So it leads to pressure ulcer. And prevention, there is a for techniques are there mainly. First one is yes, supporting surface. In prevention, we have to monitor in which surface they are be lying on or sitting on. So you have to supporting surface, you have to monitor, make sure the patient is having proper supporting supporting device is there or supporting surface is there. That is proper pressure relief technique is used to that uh, person. So you have to monitor the supporting surface is available for the particular person. So make sure your patient get pressure relief for proper supporting surface. If the patient is having improper supporting surface means you have to make sure them to use the proper supporting device like air mattress or water mattress. Otherwise, make them to use some supporting pillows. So next one is skin inspection. We already discussed that in each and every visit, you have to see the patient means you have to monitor the skin of the patient because sometimes the patient very fear about the wound and all. They don't tell you about the wound and skin damage to you. So you have to tell them to monitor and tell them to show the wound or skin. Any ulcer is there, any skin damage is there, any color change is there. You have to monitor and educate them to there is a chance of getting pressure ulcer in future if you are not obeying or you are not continuing with these techniques. So you have to tell them to do the some exercise and pressure relieving area. So you have to inspect the skin. Regular skin inspection requires overall bony prominence at risk areas. Caregiver must able to pick up the earlier signs. So you have to thorough about the stages of ulcer. You have to tell them sometimes it may be the skin changes is there, just color change is there, not at all neglect that color change. You have to inform us, otherwise you have to do the proper positioning or a moisturizing cream application and local massaging, all of things you have to educate the caregiver properly, then only you can prevent the bed sore. So next one is keep moving. Nothing but it's a positioning, proper positioning in a proper or frequent intervals. The posture changes is very important for the prevention of the bed sores. Next one is incontinence and moisture control and bowel and bladder control. Maybe a main reason of pressure ulcer. So if the patient is having incontinence of bowel and bladder, so there is any need means you have to catheterize the patient and do the needful for the bowel care. And if the patient is having incontinence of bowel means you have to frequently change the dressing once it will get a moisture. So you have to give the proper techniques for proper care, and you can apply diaper, and for bladder means you can use the contact catheter, otherwise you can use the CVDs. And next one is nutrition, and nutrition and hydration is very important because the pressure ulcer patients, there is the healing is very slow. So you have to supply the protein rich diet. They have to convey them to take the protein rich diet, and also fluid intake also you have to improve. Like that you have to inspect the patient. Inspect the patient. In care, you have to engage the patient and family in the own care. So because once you saw the patient means you can only monitor or you can instruct only at that time. So you have to involve the family members to the own care means the other time they will properly taken care of the patient. So you have to educate the family member how to give the proper care for the wound, or how to prevent the wound, and how to prevent further damage of the how to prevent the further damage. So you have to involve the family and as well as the patient. So involve the patient and families in pressure ulcer prevention and develop a contract of care. So you have to proper follow up will be arranged for that patient, and you have to continuously monitor the wound. You have to record it, and every skin changes you can assess and instruct them to how to manage the wound. And what can we do together to prevent the pressure ulcer? That is the engage the family members to the further development of the pressure ulcer. Then patient information leaflets. So if some patients may can't understand the how to prevent means if you instruct them means they can't understand. So sometimes you have to give the some leaflets like positioning regarding the health education cards, no? So that's like you can give the leaflets of pamphlets regarding the prevention and pressure ulcers and position, like you can apply. And this is in our setting we are using this type of pamphlets. How to, this is nothing but how to prevent the pressure ulcers. So so you have to position the patient every 2 to 3 hours. Every 2 hours, you have to adjust the pillow sides and give proper positioning to the patient. Any doubt you can ask. If in doubt, you can ask.
You can put your doubts in the chat box, or you can unmute yourself. Does everyone understand the session very well?
If cotton sarees means you can use for that. If cotton sarees mean you can wash it out in the antiseptic lotion and dry it in a sunlight and cut into small pieces and steam it well. So after that you can use for dressing.
There any other doubts? Okay, thank you, Sister Sreedevi, for presenting the wonderful case presentation. Thank you, everyone, for joining and being at this session. Thank you. Let's see this next session. Bye.